Hi guys, my name is Hana Choi. I come from Fairfax, Virginia, and today I'm going to be presenting a study into the reproductive health of disabled people internationally. So a quick intro to me, I go to Robinson Secondary School in Fairfax, Virginia. I'm a senior, and I'm heavily involved in my community's education and equity and volunteering in the medical community here. And my family's also a foster family. We see tons of adoptable dogs and cats from Homeward Trails Animal Shelter. Now, please note that this presentation will have mention of sexual violence. If this information is triggering or uncomfortable, please mute the conference for about 8 minutes or leave it entirely and then rejoin. And a quick overview before we get into it, I'm going to be going over background, and then I'm going to be talking about 3 countries today: the US, Ethiopia, and India. And we're going to go to conclusion, final statements and takeaways, and then credits, sources, and resources. So background, what is reproductive health? Well, reproductive health covers everything from gender equity to sexuality and sexual violence of all people internationally, and talking about the global health of all individuals. However, in my presentation today, I'm going to be talking about the intersectionality of disability and gender, and I'm only going to be talking about individuals who have female reproductive organs and those who identify as female. So why these specific countries? Well, the US has recently seen some landmark rulings for and against reproductive health. Ethiopia has seen a high poverty rate of disabled individuals, and India has a large number of court rulings protecting reproductive rights. So first off, the US, I'm going to be talking about individuals with spinal cord injuries, and then adolescents and young adults with disabilities. So in the US, individuals with an SCI or a spinal cord injury see multiple exacerbations of pregnancy symptoms, which we also see in the increased low weight babies and infants who have difficulty breathing upon birth. And for the reproductive care of these women, they have a greater challenge to get STIs diagnosed and treated, and greater difficulty getting regular preventative examinations such as mammograms, pelvic exams, and breast cancer screenings. And in the exacerbation of pregnancy symptoms, we see this kind of reflected in the abortion frequency that rises from 6.5% to 14%. And then this article from NPR right here is a really good article to see how the overturning of Roe v. Wade has affected disabled people. In the US, adolescents and young adults see a complete lack of sexual and relationship education, stemming from a need to protect these individuals, also caused by a lack of training and educational resources in some areas. And this is actually one of the few resources available to teach. So final analysis of everything that I've just quickly gone over. For individuals with a physical and intellectual disability, they see higher risk for almost all pregnancy complications and a higher incidence of providers coercing them to take invasive obstetric management, which is using C-sections over an induction. And then in reproductive care, remarkably, the US has seen steps taken so that women with disabilities are able to access preventative measures. Here's one of the resources from the CDC. However, we have seen some steps back in the reproductive care with the overturning of Roe v. Wade, but we still do see that constitutionally protected right to access contraceptives, which is so important to everyone's health. And from the lack of sexual and relationship education, we see a higher risk and incidence of sexual abuse of these individuals, with a remarkably high risk rate of 4.6 for individuals with intellectual disabilities, and a 7 times rate compared to peers without disabilities in the reports. And remember that these reports and risk statistics are always underreported and will be always higher than you see here. So Ethiopia, a quick disclaimer is that it is difficult to generalize statistics due to the high variance in development among the different regions, and that's just something to think about when we're going through this. So in Godar City, which is an urban area, we see 21.7% rate of having ever used modern contraceptives, which is affected by factors like age, relationship status, literacy, and type of impairment in which we see individuals of a higher age, people who are in a relationship, people who are literate, and people who have a limb or physical impairment being more likely to use these contraceptives. And for adolescents in Gamogopa, Ethiopia, 32.2 adolescents have ever used SRH, or sexual reproductive health services. And the discussion about SRH has a positive correlation with the use of these services. Going to the sexual activity of these individuals, 51.9% in the aforementioned sample have ever had intercourse, but unfortunately of those individuals, 11.8 had reported rape being their first time. And the main factors that influenced this was the belief that the victim is vulnerable. And analysis of Ethiopia, generally prevalence of FPS use relied upon the location, in which urban areas saw higher usage than rural areas. And thankfully, Ethiopia has focused on decreasing the distance between individuals with disabilities and FPS, but they've been largely unsuccessful because they have not been focusing on the actual accessibility of the buildings, in which they would have to build ramps and build elevators and doors that open with a button instead of decreasing the distance. And then for adolescents and young adults, there are significant vulnerability factors that we see here, in which the assumption that the victim is vulnerable and the lack of accessibility to support are really seen as huge factors why they're taking advantage of for sexual violence. And then finally, India, SRH services and rights, the legislation and the challenges to access services and adolescents. So remarkably, India has seen significant legislation and court rulings in favor of reproductive rights, from the 2011 ruling to access reproductive care for those in poverty to the 2016 ruling in favor for abortion rights for female prisoners. However, we have seen challenges with SRH services, in which there's an overwhelming generalization of people with disabilities as childlike or asexual, and in turn challenging their status as a fully functioning member of society when trying to access this care, being denied, in other words. And then for adolescents, there is no welfare in India intended to assist AYAs with disabilities in their education as they mature. That means they have no education on menstrual cycles and puberty or anything like that. And as a result, parents and guardians must persist in their own education of them. And of these individuals, socioeconomic status and the continued perception of AYAs to be weak has a profound effect on whether they are able to become independent. So finally, an analysis, SRH services and rights legislation is remarkably progressive in India, but is not seen to be particularly effective. And instead, older women with disabilities have reported that they are taking advantage of cultural and societal expectations and turning it on its head. They're using it to their advantage, and it's amazing. And in India, despite the legislation not being particularly effective, it's kind of the use of SRH services weren't shaped by the legislation, but the awareness and perceived need, in which a majority reported they were unaware of these services and none perceived them to be necessary. And then finally, adolescents, AYAs whose parents and guardians report more persistence with education, the child ended up with almost entire independence. Final takeaways. So there's still much to be done, even with the legislation to protect FP and SRH rights. In the cases of sexual violence, remember, these incidences are never the victim's fault, and it falls upon the system to handle these cases responsibly. And education about SRH, sexual reproductive health, is the first step in promoting better SRH throughout the entire world. And everyone deserves the right to dictate their own health. And then what can be done internationally or locally? So internationally, continue to put the voices of disabled women at the forefront of national efforts to extend legislation in the name of reproductive and sexual health, and hold your officials responsible for contradictions in legislation. Locally, you can start to join your very own global health initiative, just as Jada had earlier with her organization, and continue to hold open, honest conversations with friends and family about reproductive health, and correct people who perpetuate ableist stereotypes and phrases. And then these are resources that I used, and these are gender-based violence hotlines internationally. The last one is one that is toll-free and you can call anytime. And then I got the slides template from SlideSgo, and questions, concerns, please go to that link and fill out my Google form. Thank you for your time, everyone.